right, so I think, so I have a really fun talk coming up. The next one is about troponins. It's about post-troponin testing and coronary CT. So I guess it's really not about troponins, it's about CT. And I like this talk. It doesn't have too many abstracts. And for the most part, we don't really have to worry about the abstracts. We have to worry about the concept. It's a really important concept. The talk was written by David Newman. It's beautiful. It's really got it right. And I say that, you know, there's so much that's published that comes to conclusions that really are unfair. And so I really appreciate it when somebody puts it into context that actually makes sense. So what's this about? What happens in our EDs? We admit somebody for rule out MI, rule out ACS, whatever it is. And that basically takes two forms. We really worry about them, we admit them to the hospital, CCU, etc. But we don't worry about them, but we admit them to OBS. But whatever happens, after the initial workup, they then get some coronary artery workup. And so this is about that. And it's particularly about CTCA. And there are people who claim that CTCA is wonderful because if you take somebody who starts out relatively low risk and you do a CTCA on them and it's negative, you don't have to worry. They don't have disease. That's the notion. And there are 4 or 5 articles in here which prove that that's true. It's not entirely true, but it's almost entirely true. 1 out of 100, 1 out of 1,000 people who has a negative CTCA, starts out low risk, who has the disease, the negative predictive value is great, about 99%. That's the notion. So this would allow, we don't do that, but we all are complicit in this approach. So is that a good idea? So let's go back and explore that. Does that mean that doing CTCA is a good idea? So in order to answer that question, what will we have to know? Well, what do we have to think about? If it's negative, they're pretty good. That's called negative predictive values, very high. If the test is negative, in the population in whom we do it, it's pretty safe to send them home. So is that a good idea? What kinds of questions would you have to ask to know whether that's a good idea? It sounds like a good idea. It's a bad goal. It's a good question. The gold standard is a little bit unclear. It's usually what the cardiologist eventually decided. How many people eventually had a problem? And that could be muck it up, yes, because it might be a self-fulfilling prophecy. They're really not well, but cardiologists see the CT scan and they see it's normal, so they say, oh, they're well, and they give them a clean bill of health. And maybe that's wrong. But let's assume it's right for the moment. What else do you need to know?
Disease prevalence.
Okay, so you need to know the disease prevalence. What do you mean by that?
If you have a population of people that don't have the disease, then yeah, that's...
Okay, so that's really, really important. We'll get back to that in a second. Okay, let's talk about it now. So negative predictive value means I do 100 people, I do the test of them, 100 of them are negative. Who knows how many are positive? I do 100 who are negative, and none of them are sick. I say, oh, isn't that great? What's another reason why the test could be the worst test in the world, and it could be 100, I do 100 and they're all negative and they really are negative? What's the other reason? What if I did a test in here where I said, I close my eyes and turn around 3 times and point my finger, and if I don't point at you, you're well. You don't have ACS. And I would only point at one person. Everybody else, I would say, they don't have ACS. Would I be right? Do any of you have ACS? Whatever test I used in this room to decide rule out ACS would work, wouldn't it? Because you don't have ACS. So the question's a really important question. What's the prevalence? If you do any test in a group that doesn't have disease, a negative test always looks pretty good. So in these studies, there are half dozen in there. If you go, we could go through them all individually. I have all the numbers. It's not really important. If you go through them, they all say, we did the test when it was negative, the people really were well. Before they did any tests in those populations, in the groups that they did it, the incidence of coronary disease was about 1%. That means if you just closed your eyes and said normal, you'd have a 99% negative predictive value. You would be right 99% of the time because nobody was sick. In the study from Stony Brook, which is widely quoted as, this is great because after the test was negative, the negative predictive value was like 1 in 1,000. In the entire population, there was only 1 in 1,000 who was sick. So anything you do would have been good. So it's really, really important to keep that in mind. There's a difference between negative predictive value, which is the test is negative, are you really negative? That could reflect a good test, or it could reflect nobody's sick. There's a difference between that and sensitivity. Sensitivity is, if I had 100 people with the disease, how many would the test be false negative? Those are two very different things. In this case, we don't know because there weren't 100 people with the disease, there was 1. We have no idea how many it would miss out of 100. Just like if I turned around and spun and pointed my finger, how many would I miss? Probably a lot. But negative predictive value is still pretty great. You can go through all the numbers if you want. I promise you they all show the same thing. If you start out with a population who are well, any test you do that says well is right most of the time. And what's the really big take-home point from that? What's the big take-home point if we did a test, if we're studying CTCA in a population of 1,000 patients of whom only 1 is sick? Tells you that however you got into that population, that's the test that we should be doing. However we picked out these 1,000 patients, they did a really good job of identifying a group, none of whom are sick. It wasn't 1,000 out of 1,000, only 999 out of 1,000. Can you do better than 999 out of 1,000? It's impossible. So it's really, really important to keep this in mind. And I think it really shows the problem that the huge problem that we're having with rule-out ACS. I'll get back to that in a second. There's one other thing we always have to ask. There's 2 other things we always have to ask when we're evaluating a test like this. One is the prevalence of disease. What else? What are other things that are really, really important? Aside from, is the gold standard good? That's a really good question too. But what else do we have to think about? So one thing I say this all the time is we're always talking about what's the benefit of a certain strategy. What's the other question we have to ask? What's the harm? So maybe it would be true that there were 2 out of 1,000 with the disease, and if you use this test, you would get down to 1 out of 1,000, and at least you would save missing 1 patient. Now they didn't prove that. There only was 1 out of 1,000. They didn't prove that it did anything good, but imagine it did. It saved. Okay, instead of sending home 1,000 people where 2 people were sick, you'd only send home 1 out of 1,000 who's sick. That would be a benefit. But then you'd have to ask at what cost? So what's the cost of doing 1,000 CTCAs? Well, there's cost in dollars, right? We're closing down school playgrounds because we are spending all our money on quote, healthcare. There's cost in time. Patient gets admitted to the hospital. There's cost in, we took 1,000 people who were well and we called them cardiac patients. There's a real cost in that. They became patients instead of human beings. But there's also, what's the other cost that we talked about yesterday?
Radiation.
There's radiation, but imagine there was no radiation.
False positives.
There's false positives. Okay, what else? Overdiagnosis. We're diagnosing a disease that doesn't matter. And what else? Incidentalomas. One of these papers says the number of incidentalomas when you do a CTCA that get worked up and are proved to be unimportant is 25% of all the patients. So even if you saved 1 out of 1,000, that would mean 250 people you would be subjecting to some workup, which would cost money, time, discomfort, and every once in a while, lots of harm. There's a whole literature about when we find incidentalomas on the kidney, how many people we end up killing, which is a few, not a lot, but it's a few. So how many would you need to overwhelm 1 out of 1,000? Remember, it didn't save 1 out of 1,000. So you got to ask, what's the prevalence of disease? Did they really do anything good? Was it the test that worked, or was it that we were taking care of healthy people? What's the cost of doing this for whatever benefit we get? I don't see any benefit. What's the cost? By the way, 2 of the papers in here say another cost of this is that we end up doing far more angiograms and far more cardiac interventions in people who are healthy. That has lots and lots of cost. And the third question that I think we always have to ask is, what is the question we're trying to answer? And I think they're asking the wrong question. So let's think about that for a second. When a patient comes in with something, chest pain, shortness of breath, whatever it is, what's the question we should be asking in the emergency department? What's the patient-oriented outcome we want to figure out and do something about? Are they at risk if we send them home? That's the question I want to know. Right? I don't want to miss somebody who I go, it's nothing, and I send them home and they are having ACS and they're at risk for an arrhythmia and they die. That's the one I want to know about. If they're having a big MI and they die 5 days later from pump failure, there's nothing I can do anyway. That doesn't, and those you never miss, right? So I want to know, is this somebody who, they look okay to me, but they, they really are having ACS and they're going to, and if I send them home, it's bad. And that's why we do this whole mishigas, where we send them to observation units with monitors and all this crap, and nothing ever happens. So we don't want to miss that one person. What's the question that CTCA asks? Do you have coronary artery disease? Now, could you have coronary artery disease and not be that patient that we're worried about? Well, of course, everyone in this room who's over 40 at least has coronary artery disease. It's just about impossible not to. So it's a very different question. Now, let's go back to overdiagnosis for a second. If what we're trying to diagnose is coronary artery disease that's going to kill you, does diagnosing coronary disease be the same thing? Is coronary disease, is it all the same? Is all prostate cancer the same? I found prostate cancer under the microscope. Some of it kills you, some of it is worthless, meaningless. Some coronary artery disease is meaningless. You're never going to have symptoms in your life. How would we know which one of you is going to have symptoms when you have coronary disease? We all have some. Most of us have some. How do we know which ones of us? Does it matter that by the time we die, if they did an autopsy, there'll be coronary disease there, but it never had any problem. Versus, this is the thing that's going to kill you. How do we know the difference? What? Amount of plaque. So that's the theory, right? If we find a lot of plaque, that's worrisome. Is that true? There's no predictive value at all. That's not entirely true. If you have a 99% lesion, or you have more than 90% at your proximal left main, it does predict. How many people in these series have either of those? Is that the gold standard that they use? No. Nobody has that. Those people are obvious. They're not the occult person. The occult person, they're talking, used to be, on angiography, coronary disease was 70% lesion. In CTCA, they've cut it down to a 50% lesion. How well does a 50% lesion predict ACS, you're going to die? So it turns out it doesn't predict at all. It turns out that what we're looking for is this thing called vulnerable plaque. What's vulnerable plaque? Well, the plaque doesn't hurt you. The plaque builds up slowly until you have no flow at all. You're fine. And in fact, by the time you have no flow at all, you're usually fine too, because you have collaterals. Okay? So it actually turns out, ironically, that on a statistical level, it's not a big difference, but on a statistical level, you're more likely to have a coronary event with small amount of plaque than with large amount of plaque. You never have it with no plaque, but a smaller lesion is actually predicts a worse outcome. Why is that? Yes, because what we're looking for is vulnerable plaque. Vulnerable plaque is plaque that ruptures, gets a new clot, blocks flow completely, and now you have a coronary event. So how do we know which one's going to rupture? Well, we don't. But it turns out that if you have a lot of plaque, it's a little less associated with that than no small amount of plaque. Why? Well, if you have a lot of plaque, it's already told you it's not vulnerable. It's been growing for 23 years and nothing's happened. It's probably okay. And in addition, if it does rupture, there's lots of collaterals because it's been growing for that long. Whereas a 30% lesion, 40% lesion, if it ruptures, you're in deep doo-doo. So it's not a really good predictor, but it's certainly not the other way around. More is worse. It isn't worse. The only way we know which plaque is vulnerable is you had an MI. Once you have one, we know that you have vulnerable plaque. That's the only thing we know. So this whole thing is a house of cards. It's looking for the completely wrong question. What's more, it works when it works only because it's done in people who don't have disease. And it works, doesn't actually change anything except that it increases our interventions and incidentalomas and harm that we do to patients. So let's go back for a second. Some of you were practicing 25, 30 years ago. I can tell you when I started at UCLA, which is now a long time ago, we had a rule-in rate of 30%. That means 3 out of 10 people we admitted to the CCU had a heart attack. And of the other 7, more than half of them left with a diagnosis of ACS. Now, I don't know what the gold standard was, and maybe it was wrong, but more than 2/3 whom we admitted had ACS or an MI. And of the other third, half of them left with a diagnosis of coronary disease, chronic, stable, and 15% left with a diagnosis of non-coronary thing. They had chest pain for some other reason. Today, what do you think it is at UCLA? 5% rule in, 15% have coronary disease, 15% have ACS, 15%, 1 out of 7, 1 out of 6. 1/3 have some form of coronary disease, mostly stable, and 2/3 have non-coronary disease. The reason we changed was because 30 years ago, when we sent people home, we sent a lot of people home, 1% of them came back with an MI. How many come back with an MI today? 1%. All we've done is spend Is this different than your place? I don't think so. This is true nationally. In these theories, it's even worse. They had a less than 1% rule-in rate in all these studies that are in there. We basically say the indication for admission with chest pain is a chest. We admit everybody. And guess what? Any strategy we then use in the low-risk patients works. They don't have heart disease because they don't have heart disease. It's impossible to miss anybody because there's nobody to miss. Well, there is there's a needle in that haystack. Every once in a while, there's somebody with a cult disease. It's a cult. You can't find it. So what we've done is, again, created enormous amounts of harm. Think of the money involved here. Think of the time. Think of how much of our hospital is devoted to this craziness. When we all know it's crazy. And it doesn't even do any of the things we would like it to do. All it does is harm. Is this different for troponins, high sensitivity troponins? It's exactly the same thing. High sensitivity troponin, exactly the same thing. It's going to identify all the people who are occult. Yes, because it identifies everybody. What it really does is increase by tenfold the number of false positives and the number of overdiagnoses. True and unimportant. Who cares? Now, why do we do this? Well, we do it because it's good for us. We will never go to court having missed somebody if we all admit everybody and do all this crap. And we get paid more because some of them are positive, and then that ratchets it up to a higher level of care. The only problem is it's bad for our patients. It's bad for our society. Does lots of harm, does no good, except protect us. So again, I think the key issue for us is Are we going to still be an honorable profession which makes hard decisions and takes some risks, but does it for the benefit of the society and can be proud of being doctors? Or are we going to be just functionaries who do everything on everybody and say, oh, it's not my fault, I have to protect myself? I think that's really the issue. This is, just read, I didn't go through the papers individually, but you can read them individually, and David Newman does a wonderful job of framing it. But this is basically everything, to my mind, everything that's worse in medicine, in modern medicine. Using technology to prevent us, to keep us from having to think. And thinking that we're doing good because, look at that, most people who are negative are negative. But actually, all we're doing is lots of harm. And this is not just coronary disease, and it's not just PE, and it's not just screening for cancer. It's everything we're now doing where we replace judgment with technology. We gotta do better. This is terrible. We can do better. We just have to have the guts to do it. This is not a gloom and doom speech. It's come on, guys, let's go back to being doctors. Is it going to be perfect being doctors? Of course not. Some people have occult disease. We can never be perfect. There is no certainty. But what Jerry Cassara wrote in an article 25 years ago called, he was the old editor of the New England Journal, he wrote an editorial called The Quixotic Search for Certainty. When I once talked to my residents about that, I said the quixotic, they didn't know what quixotic is. I swear to God, these are smart, really smart kids. I had a rounds with 8 of them, and not one knew what quixotic was. I said, Don Quixote. I said, Man of La Mancha. Then one said, oh yeah, I know that. Anyway, so we have lots of problems. But we're never going to get certain. There's no such thing. If you have 1 in 1,000 and you think you need to have a strategy to find that one, you're crazy. We can't find that one. All we do is overdiagnose and false positives and incidentalomas and money and time and effort and labeling people as diseased and do all sorts of harm. Even if we found that one, even if we got it from 1 to 0, the harm would be immense. We don't, because that person is occult. Okay, I apologize. This is too much of a soapbox. I don't mean, this is important. To me, this is the key of what we have of modern medicine. It's driving me crazy.
You don't think you're preaching to the wrong people? You should more or less be talking to your Hoffman administrators, your cardiologists, and your government.
I do, I promise you, I do. They are tired of hearing me, and at least you guys listen. Yes, you're right. No, but let me tell you why I think this is important. It's important for 2 reasons for us to do this. One is because we live in a world, I read 500 journal articles a month. And I have lots and lots of training and experience interpreting articles. And I don't believe that normal people can do that. I can only do that because I'm privileged. I don't work as many hours as you do. I never did. I worked 16 hours a week clinically, 18 hours a week. I had time to do all these things. We can't all be experts at everything. So I got to do this particular area. You guys are in the front lines. Most of you are there seeing patients all the time. And you're hearing things. You're here because you're interested in what's the literature show and say, you can't go through this all yourself, so you got to know. Somebody's got to be able to say to you, wait a second, it's not the way they're... All these articles that prove this is stupid all claim it's great. You have to have some help saying, wait a second, it's not great. And I know some of you are very sophisticated, but in general, we need to, that's my job, is to sort of help with that. So that's one reason to do it. You came here to hear about this. The other reason is the following. When ACEP came out with its new policy saying we should use TPA for stroke, that it's proven, we didn't talk a lot about this. It's way too complicated to talk about, but it's overwhelmingly obvious to me that it's not only not proven, but it doesn't work. It causes harm. 15 years ago when I first started saying, wait, I merely said, it's unproven. Prove it. It's not proven. You haven't proved it. Now, there's so much new evidence that it doesn't work that I'm 99% sure it doesn't work. And I'm 100% sure it doesn't work importantly. And I'm 75% sure that it causes a fair amount of harm. When this policy, I say this a lot, I go over the evidence with, I give lectures where I go over all the evidence, why I think this is, if we got a scientist from Mars came down here and said, that's the evidence, you're using this? Come on, it's crazy. Well, when the policy came out, a lot of people know that I think this is crazy, and I said it a lot. So I got a lot of emails and phone calls and letters saying, what are you going to do about this? And my response was, what am I going to do about it? I'm already sick and tired of talking about this. What are you going to do about it? So I do talk to my hospital administrators, and I do fight this battle, and it's useless if I do it. Fabulous. Your college? Yes. Yes. So I'm asking you to do the same thing here as you guys have done. The Australian College has put out a wonderful position paper about stroke. I'm asking you, all of us, to do the same thing. This is not up to me. I'm asking you to think critically and to say, wait a second, this is crazy. I'm not going to admit everybody who has a chest to an observation ward when I know they're fine. I'm going to talk to patients, and I'm going to say, you're fine. Come back if you have problem. But I'm not going to buy into this, let's do troponin. So it's sort of ironic. People say, how do you say that when they also hear me say, never do one troponin, always do two? When they hear me say, don't do a CT alone, do a CT LP. The answer is, don't do a CT of the neck, do a plain X-ray. No. The first thing is, the vast majority of patients need nothing. The few who need something need a good test. Tests are not bad by themselves. If we use them correctly, they're really good. So if you really need to have a workup for subarachnoid, you need to get a CTLP. If you really need a workup for coronary disease, you don't need one troponin, you need two. One isn't good enough. One troponin is 90% sensitive. If you're really looking at high-risk patients, you don't want to miss 1 out of 10 of them. Then you need 2 troponins. For all of the examples I've given you, I believe the large majority of people don't need any tests. The ones who need a test need the right test, and the right test is not just halfway. So the more important thing is don't do any tests in the vast majority. But then in the ones you're going to do it, do the right test. That's what I believe.
So before you end, are you recommending that they follow up with their in the outpatient setting?
No, I think it's the same as, any of the patients you send home. You send home somebody who has a cold, come back if you get pneumonia. But don't go to the doctor to go looking for pneumonia if you have a cold. So I think what we need to do is say, we have a tremendous safety net. Look, some people are really, really present crazy. They look fine and then they turn out to be sick. And so I want you to come back. I want you to come back if, we have a lousy primary care system in the United States. Should they have primary care follow-up? Yeah, just about everybody should have a doctor. But I wouldn't worry them about now you need to go get a workup. No, right? This is not coronary disease. I'll tell you, go even further, which is I have a lot of patients where the resident says to me, we have to admit them, I know it's a bad story, but the person has already had a heart attack, or they're an old person and they're really at risk. And I think, wait a second. Yes, they're an old person, they are at risk. Yes, they had a heart attack, they are at risk, but they're at risk tomorrow and the day after a day. This is not a heart attack. What they're having today is nothing. So we shouldn't elevate it into you need a big workup. Make sure you go to your doctor. No, make sure you come back if you get shortness of breath, if the pain gets unbearable, whatever it is, but no, I don't think we tell them rush to your doctor because they're going to do all this crap because they're under the same pressure we are.
I was just referring to an article where they say prominent cardiologists and prominent journals have called for a default practice, a routine following rather than non-invasive clinical.
Yes, they do. And yeah, my note on that statement is that the ACS and the American College of Cardiology say they all need some test because there's so much evidence that all the follow-up tests are lousy. They don't pick which one they want. They say, but you need one of them. We're not going to tell you which crummy test to do. Of course, my note on that is, what else are they going to say? Of course they want all these people to get into their hands. That's called car payment. Choosing wisely, you heard a lecture about this, and there's all these things that are in choosing. It's a great thing. It's important, but it's mostly bullshit. So in our choosing wisely, ACEP, we didn't include don't do no-risk chest pain. That's a much more important one than the 5 that they did choose. Same with no risk. There are a lot of things we could have done. The cardiologists have 5 things that they said. They forgot to mention in their Choosing Wisely campaign that they should stop doing stents on stable coronary disease. $4 billion a year in their pockets, they didn't mention it. Of course they want you to do some test. That gets them to them. And then they get to do all this stuff they do. And then they get to say, wasn't it great because these people really had coronary disease? Not because they saved a single life or a bad outcome, but because they identified disease. Anyway, so you know what I think, right?